All right, welcome everyone. Thank you for joining us today for our funder discussion on supporting parent and caregiver mental health and well-being. I'm Rena Large. I'm the program manager for the Early Childhood Funders Collaborative. In the interest of time, if you haven't already introduced yourself in chat, go ahead and tell us you're in the room. Today's call is part of a series of funders calls that we have been hosting on first and third Thursdays this year around some of our priority interests, including racial equity, partnering with government, and engaging and elevating authentic voices. Today's topic is intertwined with all of our priorities, and it's an outgrowth of some discussions we've been having within an ECFC member work group on early relational health. I'm really grateful for our moderator today, Elizabeth Krause from the Caregiver Fund. She's a member of our early relational health work group, and she helped shape today's call to help us explore different ways funders are coming into this space. And on our event page later, we will have resources that speakers mention today, as well as some resources shared in advance and the event recording. And so with that, I will turn it over to Elizabeth, and she's going to provide some additional context for this discussion and then introduce our speakers.
Hello, everyone. Thank you so much, Rena and ECFC. I am grateful to Rena, who has been such a high quality partner in organizing this event. I absolutely adore working with you, Rena, so thank you so much. And thank you to all who are joining us today to have this conversation, one that we believe is about time to have with the early childhood community of funders. I am pleased to note that as of Monday or maybe Tuesday, like Mercury is no longer in retrograde. So we have high hopes that technology will behave. Of course, that is never guaranteed, but we have hope. A little bit about Caregiver Fund and the perspective I am bringing in as moderator today. Caregiver Fund is about 3 years old, so we are relatively young. We work deeply in our home state of Washington and make national investments as well. We are a prenatal to 3 mental health funder. Just this morning, somebody asked me, is that a thing? And yes, it is a thing because we are making it a thing. And that means that we focus on infant and early childhood mental health and maternal and parent and caregiver mental health, and that we center families affected by trauma and toxic stress, which we know are magnified by racial, gender, and economic injustice. What brings us here today? As Rena noted, this was a spinoff of a conversation that started in the ECFC Early Relational Health Group. I had a number of thought partners to help me and ECFC think about how to get this conversation going. So you know who you are. Thank you. I don't think I need to break it down for anybody here today, but to put a fine point on it, very young children are entirely dependent on their relationships with their primary caregivers and parents to survive, grow, develop, and thrive. And parent and caregiver mental health is a factor in the relational context for that development. And so the childhood funder group, the early childhood funder group, really wanted to know whether early childhood funders are thinking about and doing things about parent and caregiver mental health and well-being. And so that can look broad, actually, and that's what's so cool and inviting and what can also make it feel amorphous. There are highly clinical views on mental health issues, such as postpartum depression, psychosis, schizophrenia, and there are highly holistic understandings about what contributes to mental health and well-being. And those can have to do with financial stressors that come into play because babies are expensive. Relationships with other adults are expensive. It can also have to do with a parent or caregiver's own trauma history. So all of these things swirl into this conversation. And we want to invite the different perspectives because we think it needs to have more connective tissue and sharing, and ultimately more parent and caregiver mental health support. So today we have a number of early childhood funder panelists. They are going to speak going from, I will say, narrow to broad. Those sound like judgmental terms. They are not intended to be. So if you don't think of yourself as narrow or broad, I apologize. But we are going to go with Rebecca Alderfer from Zoma Foundation first. They have done very specific maternal mental health work. Then Tonya Spence from Irving Harris Foundation, who enters the work through an infant and early childhood mental health lens and perspective. And then Atiya Weiss from the Burke Foundation, coming in from more of an adversity and early relational health perspective. Their bios are available on the landing page for this event. I will not read them to you. Nobody wants that. So please check out their bios online if you would like to know more about them. They will each have about 7 minutes. We are just going to scratch the surface, really trying to get at the why they, as funders that touch early childhood work, also invest in parent and caregiver mental health and well-being. And then how is it defined? What does it look like? Our sense is that there are many early childhood funders that are doing things to address parent and caregiver mental health, but don't have that lens and don't think of it in this way. And by being a little more explicit about it, we can expand the conversation and coordination. And our sense is that there are others that aren't taking it into consideration who could have higher impact outcomes for children if they did. So we'll go through the panel. Again, each speaker will have about 7 minutes. And then, like any basic moderator, I have some questions in my back pocket, but we want this to be interactive. We only have an hour. We want to hear what the questions are from the group. So I will really try to prioritize either your questions or what you would like to contribute to the dialogue. So with that, I will pass it to Rebecca.
Hi, good afternoon, everyone. It is such a pleasure to be here with you this afternoon. I want to thank Rena and Elizabeth Krause for the invitation to come chat with you and share some of the work that the Zoma Foundation is doing and how we look at this issue of what we call perinatal mental health. I know we're going to hear probably lots of different terms throughout the course of the hour. And the term that we use to define kind of the portfolio of work that we have is called perinatal mental health. So the Zoma Foundation is part of a broader organization called Zoma Lab. You can find us at www.zomalab.com if you want to learn a little bit more about us. But primarily, we're a private family foundation. We're located in Denver, Colorado. And we tend to focus regionally. So a lot of my work is focused on Colorado. But saying that, we also work nationally because, as we all know, a lot of the systems change and policy solutions don't just live within state boundaries. They expand to federal or even across states. And so we do a lot of that work as well. In the Zoma Lab Foundation, as Elizabeth said, I maybe have one of the most narrow portfolios that you're going to find in this area, in that we specifically have a line of work and a strategy that's focused on perinatal mental health. And if you want to flip to the next slide, Rena, I can sort of lay out what that looks like. When we say perinatal mental health at Zoma Lab, what we're referring to is the period between conception and sort of 1 year postpartum, so 12 months postpartum, which can almost take you to 2 years, right? We're looking at about a 2 year period of time Perinatal is defined differently if you look it up in the Webster's Dictionary, but that's our definition of it. And the reason that we got so focused on perinatal mental health is really a couple. One of our founders is a child psychologist and has a deep respect for the bonding and the nurturing environment of raising children. We also have an issue area where we focus on the prevention of child maltreatment. Clearly, these two things are kind of closely linked as well. And also out of lived experience. I think, we've come to establish that perinatal mental health complications are the most common complication in pregnancy, 1 in 5 women, and we think that's an undercount. Certainly in Colorado, we have data to the contrary. And so it's an incredibly compelling issue because it not only affects the mother, it affects the relationship with their child and potentially their development, and it affects the entire family unit and the development of that family unit. So when I say perinatal mood and anxiety disorders, I'm talking about a whole host of issues that include depression, anxiety, obsessive compulsive disorder, PTSD, bipolar, and certainly in the worst cases, perinatal psychosis, which you tend to hear about more. You tend to hear about depression and psychosis more, but all of these are part of a spectrum of mental health conditions that can be experienced both during pregnancy and throughout the years after. I think all of you are probably aware that perinatal mental health is sort of an equal opportunity condition. It affects women in their first pregnancy or in their fourth. You may have a history of depression or risk factors, you may not. And certainly what we're learning is that it doesn't show up at convenient time periods for healthcare. So it may not show up at your 6-month visit or your 6-week visit. It may show up at 4 months or 6 months postpartum. And then you're really in the hands of pediatricians at that point. And they're not set up to do that kind of care. And I think the other thing that's been very well established in literature is that when left untreated, perinatal mood and anxiety disorders have multi-generational consequences, like I said, both for the mothers and infants. Next slide, Rena. A few Colorado stats. We know from our Maternal Mortality Review Commission that mental health conditions are one of the leading causes of death in Colorado for mothers. In a survey that we run, a longitudinal survey, we're seeing 30% of Colorado mothers have an elevated Edinburgh-3 score, indicative of possible anxiety disorder, 30%. In our rural areas, we're seeing about 20% of women reporting depression during their most recent pregnancy. And asked whether they had a healthcare worker talk to them about these issues. What we're seeing is that around 74% are saying at a well child visit, they were asked. We're seeing more like 80% in sort of an obstetrician type of setting. But what's interesting is that when you look across the time period, like prenatal, postpartum, and well child, we're only seeing 55% of women in Colorado say that they were talked to consistently throughout that time period. And then, of course, I think these numbers are a little out of date. They're 2017. But when you look at diseases and conditions that affect a similar ratio of people in our society, this is horribly underfunded as an issue. The research, the drugs, the treatments, modalities, the ways we can scale interventions don't have the kind of investment that the numbers would warrant. And just lastly, I think I have 1 minute, Rena, on the next slide. I think there is so much potential. Zoma's been working in this space for 10 years now, actually 12. 12 years of investment. We've put millions and millions of dollars into this in Colorado and are seeing wonderful outcomes. So there's certainly lots that can be done. It takes time, but there's so many ways that we can get traction around this issue. And I think what's exciting is that we're seeing that traction build nationally. And that, I think the most recent health affairs issue and the briefings that are going on and the federal legislation that's at play, it's time. This issue is in its moment, and I think it's very exciting to see. Thank you all so much.
Thank you so much, Rebecca. Tonya.
Hi, it's so nice to meet you all. My name is Tonya Spence. I use the pronouns she, her, hers, and I exist and live on Lenape land in New York City. I work for the Irving Harris Foundation. I've been here about 4 months, but I have previously been working with the Irving Harris Foundation because they funded a program that I oversaw in New York City called the Jewish Board. I was the Senior Director of Early Childhood Services back then. I am now the Director of Infant and Early Childhood Mental Health at the Irving Harris Foundation. The foundation really it's a private family funded foundation that serves nationally and internationally because we fund some programs in our early childhood mental health portfolio in Israel. The foundation has several areas that it funds: reproductive health and justice, the arts, infant and early childhood mental health, and early childhood. Today, I'll be talking about infant and early childhood mental health. Irving started the foundation and really started funding people because he believed that people would need a workforce trained that understood infant and early childhood mental health, and that back when he started funding those who were doing infant and early childhood mental health, there weren't many because it's a pretty new field in many ways, about 40 years old. That the country, by the time it woke up, there wouldn't be a workforce that had been developed and had been thinking about this work. And so he began funding leaders around the country who then gradually became a variety of leaders around the country, and then gradually became a part of something called the Professional Development Network. And so now we fund about 17 programs, again, around the country and in Israel. And we have, in infant and early childhood mental health, what we talk a lot about is the fact that it's all about the relationship. And so when we say that, clinicians hold the parents so that the parents can hold the child, and that the work can be done in the relationship. So we fund varying programs, but I'll talk about one that sometimes ripples into many programs. So one of the programs we help fund that develops the workforce is child parent psychotherapy. It's an evidence-based trauma treatment that's used across the country in different places. And what they really look at doing is supporting parents and their children who've had some level of trauma. And when you think about trauma, often we think about the individual, but in CPP, what we talk about in the infant work is it's about the relationship and where that trauma has affected both the parent, the child, and the relationship, and it's not separated out. And so often when people talk about infant mental health and they talk about the parent and they talk about the child as separate, but the thing to hold is that in order for a child to regulate under 5, any child under age 5, all infants co-regulate with the adults around them. And so the work that's done in trauma treatment really is thinking about and holding how to help support and develop what issues came into that relationship when the trauma occurred, whether that trauma is sexual abuse, community violence, historical. Often there's several traumas, and the work is to tease them out and to really think about how that trauma has affected the parenting. And so usually one of the things we keep in mind is that the parent is the protective shield for the child. And so when a child has had trauma, is there work that can return the child to feeling like the parent can be the protective shield, the person who holds and helps support and keeps them safe? Because safety is the biggest piece of trauma, right? Trauma often is too much, too fast, too soon. And so we always want to be holding that about trauma. And so as we capacity build and think about that across the country, one of the things that CPP and Harris has really been looking at is how do you also think about racial equity in this work? Why are so many children and parents who are getting treatment often from Black and Brown communities? And then if that is the case, how are we developing a workforce that ensures Black and Brown clinicians are included and being developed? How do you think about and hold that supervisors and leadership are developed who are Black and Brown also, who speak different languages, who show up from the communities? So if you went around the country and saw the different CPP providers, something that Sean Dragos-Ippen and her team have really worked hard to do and develop is to think about how do we also develop the leadership to be holding and thinking about what community do you exist in? How do you hold and think about that community? And then how do you start the work of child parent psychotherapy? Because although it's a trauma treatment, depending on community, you also want to be holding the mental health of what is happening in that community. How might that be affecting the mental health and the child and the parent? And how can we be supportive in thinking about the different systems that might need to be impacted in order for a child and family to feel and be kept safe within those communities? So a lot of the work is not just about doing the treatment, but in the treatment, what surrounds the child and the family? Who surrounds the child and the family? How do we collaborate and capacity build in the communities? And what are some of the ways as a foundation we can help with that? It is also why we also do some policy funding in the infant and early childhood mental health piece, because we want to be thinking about, are there policy aspects in the different communities and the ways that we show up? And are there ways that we can be moving that piece in the communities that we serve? I'll pause there because I only have 25 seconds.
Thank you so much, Tonya. And now Atia.
Hi, everyone. I'm delighted to be here today. My name is Atia Weiss, and I'm the Executive Director of the Burke Foundation. I was honored to join the Burke Foundation about 5 years ago as their first employee. I have a background in public health and finance. I spent 11 years with Pfizer and the Pfizer Foundation managing their global health portfolio, and another 5 years with JP Morgan's Philanthropy Center. Our team at the Burke Foundation is focused on supporting programs and policies that foster the healthy development of young children and families and build a cycle of opportunity across generations in New Jersey. Our approach comes from this unwavering belief that nurturing responsive relationships between caregivers and babies foster health, well-being, and resilience for a lifetime. It's also very important to note that New Jersey, while we're one of the wealthiest states in the country per capita, has some of the worst maternal mortality rates in the country. We're ranked number 47th out of 50th for maternal mortality, and Black women are 7 times more likely to die of pregnancy-related complications than white women in New Jersey. The national average is about 2 to 3 times. So accordingly, we made a strategic decision to do work aimed at improving maternal and child health and advancing health equity by targeting our support to families of color. We focus our funding in 3 pillars: healthy births and strong beginnings, healthy parent-child relationships, and high-quality early learning and care. Next slide. In 2017, we didn't have a specific mandate or a mission. We were thinking a little bit about kindergarten readiness, but we wanted to test our assumptions. So we began our journey doing a field scan of prenatal to early childhood years, and we connected with thought leaders like Dr. Nadine Burke-Harris and Dr. Jack Shankoff, and learned about the impact of something called adverse childhood experiences. We learned and read the landmark 1998 CDC study that found that ACEs can have lifelong detrimental outcomes. ACEs can come in many forms, as you can see from the slide, parental separation, maternal depression, violence, abuse or neglect, substance abuse. Nearly 50% of all kids in New Jersey have experienced at least one ACE, and children of color and those in low-income communities are more susceptible to experiencing ACEs. High doses of adversity, if not properly addressed, can lead to something called toxic stress. Children growing up with toxic stress may have difficulty forming healthy and stable relationships. And this can then lead to long-term behavioral issues and costly conditions like cardiovascular disease, diabetes, and depression. The field has matured a lot since that original 1998 study. And researchers began looking at the conditions that cause the specific traumas that were cited. So looking at the bottom of the tree, there's community and environmental conditions such as racism, poverty, bullying, community violence that are very important to consider. And having a background in public health, I really like this visual because it shows the upstream root causes of trauma. As a foundation, we came together with other funders, the Terrell Fund and the Nicholson Foundation, in partnership with the New Jersey Department of Children and Families, to start a public-private partnership focused on awareness, training, and community at its center. We're still very much pinching ourselves that we got to hire David Ellis from Minnesota to sit in our state government as the first executive director of the Office of Resilience. He, Laura Porter, and Rob Anda are some of the most recognized trainers around ACEs in the country. Next slide, please. It was a little daunting to figure out what to do after we learned about ACEs. So one of the frameworks that we use to address the impact of toxic stress are 3 principles developed by the Harvard Center for the Developing Child. The 3 of them include, first, reducing sources of stress on children and families, strengthening core life skills like emotional regulation and executive functioning, and building caring, supportive relationships. These are very simple ideas, but the framework lends itself to what many of us care about: equitable prenatal, birthing, and postnatal care, paid leave, economic stability, mental health supports, high-quality childcare, and effective systems of care for families and children. So our journey on ACEs led us to what we believe is the antidote: positive childhood experiences, and the idea of building healthy relationships between parents, caregivers, and children, and strengthening the villages and communities that support families. Next slide. This framework around resiliency has very much inspired our grant making. The Burke Foundation is making a series of investments focused on upstream initiatives that increase protective factors and reduce risk factors as early as possible in a child's life, ideally starting prenatally. So I'm going to share with you a couple of initiatives that we've been supporting over the last couple of years. Community doulas. So community doulas are a personalized approach to enhancing prenatal and postnatal care. Doulas are trained non-medical professionals who are trusted members of the communities they serve, and they provide physical and emotional support before, during, and after childbirth. We've been supporting the first bilingual community doulas program in our state, in Trenton, New Jersey, and it's served already 75 women. Many of them are undocumented or underinsured. All of the women in our program have been screened for postpartum depression and referred to services if needed. Additionally, the impact on maternal and infant health has been remarkable. A close to 70% reduction in preterm births compared to a Medicaid birthing population. Looking back on the programs that I've been working on over the last 2 decades, this is some of the most meaningful impact I've ever seen from any initiative. The second program that I'd love to bring to your attention is universal newborn home visiting. We launched Family Connects, which is a model that was started in Durham, North Carolina. It's a universal nurse home visiting program. So we're doing a pilot in Mercer County, which is where our foundation is located. And it'll be offering services to 3,000 birthing people who deliver at a local hospital. Every family will receive between 1 and 3 nurse home visits. At the visit, a nurse conducts a health assessment with the mother and baby, and then looks at what they want and need, and connects them to services like mental health, food, childcare, housing, and lactation support. Excitingly, this summer, Governor Murphy signed a bill to make universal newborn home visiting available to all families in New Jersey. This is a real moment to celebrate, and it's going to touch 100,000 new mothers and caregivers every year in our state. The third program that I'd love to bring to your attention is Healthy Steps, and I'm sure many of you are familiar with it, but it's this idea of embedding a specialist, a licensed social worker, or a psychologist in a pediatric practice to enhance the pediatric team with more supports and more referrals. So we're piloting the first Healthy Steps site in New Jersey. We've hired 3 incredible specialists at Hackensack Meridian, and they have a lot more time beyond that 15-minute pediatric visit to connect with families on issues like sleep, discipline, lactation, nutrition, mental health, and referrals for social needs. All of these initiatives that we tend to support touch families during a critical window when families are most vulnerable. They promote relationship-based care, primary prevention, and community connections. Next slide, please. And I just wanted to end my section by saying I believe strongly that your ACEs score is not your destiny, and that supportive, loving caregivers can really buffer the effects of ACEs Really believe that this work is multi-sectoral and we need everyone at the table. And from working abroad for many years, just want to share one of my favorite African proverbs. If you want to go fast, go alone. If you want to go far, go together. Thank you very much.
Okay, well, thank you to our three members of our funder community and panelists. Rena, I will, okay, however you want us to be displayed. I will take moderator's prerogative and throw out the first question, and then we're going to open it up to make it a group dialogue. So this is a part observational question, part opinion question to our panelists, but why do you think caregiver and parent mental health is invisible or siloed off from any efforts to improve early childhood outcomes? You and the panel see the connection. What do you wish more early childhood funders saw that you see, and what has helped you to bring others along? Like what framing or angles or proof points have brought other people into like being one of the dogs with the branch in the mouth?
Okay, I'll bite on that, Elizabeth. So why do I think it's siloed? I think anyone who works in healthcare can see that this is a huge moment of transition in care between being pregnant and then being postpartum and having the baby really be the focus of all childcare for the next 3 years. And what happens in that transition is that the mom and the family really get lost. So, you're seeing your obstetrician or midwife many times during your pregnancy. You have labor and delivery, and then you're just off the map for about 6 weeks. And unless you live in a state with Family Connects, we're looking at it in Colorado also, there's really no one checking up on you, or unless you're in the NFP program, the Nurse Family Partnership Program. And then you may or may not make it to that 6-week postpartum visit. Many don't, lots don't. Mostly it's focused on your physical health after the delivery. And then you're in the pediatrician's office, and the pediatrician is typically not responsible for the care of the adult caregiver, or necessarily empowered to do so, or paid to do so, or feels comfortable writing down what's happening and prescribing to the caregiver, the mom and caregiver family. So there's just a real loss there in continuity and connectivity, and our health system really exacerbates that.
Other perspectives?
Yeah, I just want to add, it was really eye-opening. We honestly were going to do work initially around early childhood development, go after kindergarten readiness. And I think it was kind of mind-blowing when we learned about adverse childhood experiences and sort of the trauma underlying a lot of our kind of social issues. And I think it really helped, our board to talk to experts in the field, and also those that have lived experience. And just a shout out to very much to Ira Hillman at the Einhorn Collaborative. So he came to one of my very, very first board meetings, and we stayed in touch, and we built a lot of our first investments around Ira's knowledge and Einhorn's investments. And very personally, I think Ira really inspired me to learn more about this area to figure out how to be a better parent to my kids. So it's very personal in a lot of ways. But I think learning, is especially when you've got a group, can be, is a really helpful first step. Our entire team read What Happened to You by Dr. Bruce Perry and Oprah Winfrey. It's a really, really terrific book that very much digests things like the brain science, healing, resiliency. And it's wonderful to just sort of have a common language to work from. And then the third thing I think that's been helpful too is Dave Ellis, our ED at the Office of Resilience, he does ACEs trainings now virtually every other month. So if anyone's interested or anyone on their teams are interested in jumping in, please let me know and I'd be happy to connect you to one of our trainings happening.
You know, I think children are cute. I think people like to fund and do work with children because it's, you know, they're cute and it's nice to think about their development and to think about what could be for them. And we forget that in order for children to grow and thrive, the adults in their lives have to be growing and thriving. And I also think when you think about children in communities, the communities we most serve have the parents that most people don't want to serve, if we're really honest. We really struggle as a country with talking about what we've created in communities, the divisiveness, the way we've spent money in different communities around education, who gets housed and who doesn't. And so having a real conversation about how as America, we've colonized our own ways of being and we've really done harm to varying communities also has to be at the table. And I think that's a hard conversation to be at the table too. And so when you think about working with children and families, you have to hold all of those pieces. And when you go in, you have to acknowledge that sometimes there are things we cannot fix right away. And I think that's also hard for providers and people who fund the work.
Thank you. Yeah, all really important considerations in getting to solutions. I am going to see if we have questions or perspectives from the group. Rena, can people just unmute themselves or do they need to raise their hand?
Oh, they can unmute themselves or type in chat.
Hi, this is Nancy Jost from Minnesota. And one of the comments I wanted to make and have you comment on is that sometimes as philanthropists, things take longer to fix than we want them to. And I think that sometimes gets in our way because the work that we're trying to do doesn't take place, isn't finished in 1 or 2 years. Any comments about that?
Hey, Nancy, this is Phyllis. I'm 25 years in now at the Harris Foundation, which is somewhat shocking. And I will say persistence pays off. So it's not that in my lifetime, we're not gonna fix these problems. But if you have an idea of a North Star and you organize your work around that, you can look back and see progress. And sometimes we do a lot of policy work. It's 3 steps forward and 4 steps back. And sometimes it's 3 steps forward and another 3 steps forward. And it's also about being in a position to be activated when an opportunity happens. So I guess my message to you and your board is that staying with something in a focused way over time, but remaining with a North Star, but remaining flexible and opportunistic allows you to take the most advantage when things do open up for us to lift up or elevate or raise up these issues in ways that will connect with different audiences at different times. So I feel like right now, the way people are connecting around this is the level of stress and anxiety and trauma that communities have experienced for many, many reasons and are continuing to experience is now so universal in the last 2 years that we're seeing opportunities to talk about investments in mental health that we never saw before. Or we've been able to elevate and lift up voices from the community around community doulas. I mean, we started community doula work 25 years ago. Atia, you make me smile. You know, I think that you have to sort of have the long-term view about the momentary opportunistic sort of approach. And I think over time you make the change. I think we are such a community that wants immediate gratification all the time. And, you know, if these issues were easy to solve, we would have solved them. You know, these are really complex, challenging issues. So I think we have to set what our expectations are realistically, and then make the progress we can make and bring others along with us, so that when we're no longer doing it, somebody else is doing it. And I think, you know, I don't know, that's how I would respond to you. Like, I can see how far we've come, but in the day to day, sometimes it feels like we've gone nowhere. So I feel like you have to sort of like have that ability to have that perspective and be ready and nimble to take advantage.
Yeah, and I would just also add, I mean, Phyllis, thank you, because Phyllis shared with us the community doula model many years ago when we used to help, you know, we've been working with Health Connect One, which has been fabulous. But I'd also say, Nancy, it's such a good point. You know, like this stuff, it's hard to see population level impact, you know, quickly. You know, I've really appreciated and learned so much about working more closely with community, and we're going to keep doing that. So I think that's really exciting. I also feel like philanthropy has an opportunity to also make connections with government, you know, and I think if your county's open to it, your mayor's open to it, your governor's open to it, a commissioner's open to it, I've just seen such catalytic power where like philanthropy and community can work together, and then government can take it one step further, like kind of what happened with Governor Murphy and the Universal Newborn Home Visiting Bill in New Jersey. So I think look for those opportunities, because I think that's going to get us from point A to point B much faster.
I would also encourage that everybody thinks about the difference between sort of like abundance and deficit. And when we go into communities and we see them as having deficits versus abundance and skills and their own resources, which is why community work is so important, we approach it differently and outcomes are different because the community knows the solutions instead of people who don't know communities coming in and forcing solutions.
Yes. Shannon, I see your hand up.
Well, I think it's a little bit of a link to something that Atia just said, which is, I mean, not surprisingly, given who I am, like question about policy. I mean, that's really, I mean, so a lot of you work on like the systems level. And so I'm wondering what progress or thoughts you have about how you fund advocacy, how you lean on the governor or the feds, because I mean, I think the path, the one of our core ECFC things is like, and nothing we're working on is going to be fully funded by philanthropy, right? Like, you know, there's just not enough money. And so like, we're always working on this, like, okay, what's the philanthropy role? And then how do you use that to convince Medicaid or the governor or whatever? So I'm really interested in how you guys are seeing that link between your practice investments and your policy advocacy and government partnerships.
I can take a first stab at that, Shannon. So as a private foundation, you know, we certainly have limitations on what we can fund directly around policy and advocacy, but we've found lots and lots of ways to really influence all of those systems. So just a couple of examples, you know, to enable telepsychiatry consultation. You know, we've been able to really put forward kind of the evidence there, which then has allowed people to change the rules around reimbursing those kinds of services. We were able to fund with the California Healthcare Foundation some new HEDIS measures, which now advocates are taking and going to MACPAC and the other organizations that are looking at the core set for Medicaid for adults and kids and advocating on our behalf to have those included. I think the other piece that we've been able to do is really highlight the research around peer support specialists, which have led to new legislation in Colorado around really adopting that as a workforce, not only for substance abuse and recovery, but for perinatal mental health. And so I think there's lots and lots of ways that we've been able to influence policy at both the state and federal level.
I would just
just adding that I think your point is so well taken in terms of the fact that private philanthropy will never be enough. And so what we've tried to do is like map every single one of our programs and what are like the pathways to sustainability, to scalability. And we'll make corresponding grants for that sustainability work. Whether that's like to Manat Health or to like the New Jersey Quality Institute, really working through like channels around Medicaid funding, sort of the measures that you're talking about, Rebecca, where we're making sure. So we're kind of managing and trying to help our partners like, look at a good pilot and see that it's effective. But then we have a complementary set of partners that's also working on the advocacy policy side as well.
And Atia, what's going to fund the universal family, the universal home visiting? Is it?
It's insurance, yeah.
Okay.
Yeah, so it's mandated for the insurers to cover it.
Oh, wow. Okay.
Yeah. And we're sitting on an advisory committee where they're really trying to take that apart and what that looks like with our state agency that's focused on insurance. But like, it's definitely complicated between Medicaid, private insurance, and then ERISA plans as well. So it gets pretty complex quickly.
I see Priya has her hand up.
Yeah, thank you. I'm Priya. I'm an entrepreneur in residence at Promise Venture Studio. And I'm just really curious as I enter this work, building a venture in the postpartum space centering BIPOC communities. I've seen that there are a lot of really wonderful local approaches to this that have been going on for years and years, and there isn't a lot of voice to those approaches. And I'm just wondering now that there's more momentum around this, and we're starting to highlight mental health for birthing families at a national level, and there's so many wonderful policy shifts, how we're thinking about sharing those lessons, because I see that localized approaches can be wonderful and they don't always need to scale, but I think the lessons from them can really serve across the board. So yeah, I'm just curious as funders, how you're thinking about that and sharing some of those lessons.
I think I think local solutions are great, and it's great to, and we try to do our best in terms of like when we're looking at something like what else is going on in another state, another county, what else is happening. So that we try to do that benchmarking and research, but it's, I would say that I think it kind of behooves us as sort of the funding community to think about more money and supports for documentation, for, getting the word out about what the programs are, if it's possible to add some evaluation dollars to it. I think it's so helpful to be able to package the work, no matter at what level, so that way it can be shared more freely.
Yeah, I think agreed. I think not enough happens. We do, so at Harris, we have something called the Professional Development Network. We do tend to have articles that come out, white papers that come out that really share lessons learned. In addition, we meet yearly. That gives an opportunity for us to cross-share lessons learned in the Professional Development Network. And I'm sure there's still more that needs to be held. Articles go into 0 to 3. And so you'll sometimes see professionals that came out of and or did some of the work that Harris has funded write articles that share lessons learned. They'll give case examples. There's times where they'll write up what's occurred and what they've learned from it. But I do think when it comes to certain programs, right, community-based programs, that's the work. And so maybe that's an opportunity for all of us to think about how we do that together, right? You have all these early childhood funders. Is there an opportunity to come together and think about how something could be put out from some of the communities that are doing this work deeply? And they don't talk about replication like we do because they know that their programs are actually for their communities. So you're right, lessons learned would be the big pieces of it.
Great, thank you, Priya. There were 2 questions that were actually submitted before this session that tie into a question Nancy put in the chat or a comment, and it has to do with both rural need, and Rebecca, you touched on that a little bit, as well as like what are some of the workforce solutions we should be thinking about. And often workforce challenges come up in the context of trying to get more support to families in rural settings. So to our panelists, what are your perspectives on either and or the rural or workforce pieces, both and or one or the other? And I think that might be the last question we have time to talk about, but I will put that to the group.
Yeah, I can touch on both of those real quick. We have a lot of rural areas in Colorado. And I think one of the ways we've been approaching this issue is to really think about how you can use extensions of care and develop a continuum of care that will support people across the state. And I think a couple of things that I've probably highlighted earlier today is, how do we really task shift, away from licensed clinical providers to more peer-based approaches, to more kind of support group approaches, to more teleconsultation programs. PSI, the Postpartum Support International, just won a large award to do a 24/7 hotline that will be available to everyone in the country around perinatal mental health. And so I think there's a lot of developments that support really getting out into rural communities. And of course, broadband certainly and different, it also supports language, stigma, is having these supports available to everyone sort of across the state. I think when it comes to workforce, like I said, I think we're never going to be able to have enough of the highly trained folks that come from communities that look like the folks that are in need of care. And so we're definitely exploring those different approaches to how do you create care models that allow people from communities with lived experience to be a part of the solution, and doing a lot of work around that. I think Healthy Connects and Healthy Steps are ones that we're very much invested in Colorado. And then I think we need to look at specialties. Irving Harris has really taken infant and early mental health, childhood mental health to a whole nother level. And I think, the next phase is really looking at perinatal mental health and how you create the certifications and the professionalism around that field as well.
I appreciate that, Rebecca. I do think task shifting and moving people away from mental health clinicians always to peers and community partners, right? That's what the doula work really showed us. And then in New York, we had 2 different groups come in, one from India and one from Zimbabwe, that really demonstrated how you can take task shifting and move it to a community and create mental health and healthier communities, because you use the leaders that already exist within the communities. So in Zimbabwe, they use the grandmothers, right? And so they called it a grandmother project, and they trained and developed them. And so when women would come and sit with them and have conversation, they were able to really think with them and actually work toward supporting the mental health of the women. And if you think about infant and early childhood mental health consultation, one of the things that the research shows in it is that only 5% of the children who will need a higher level of clinical care. If you go in and do infant and early childhood mental health consultation into preschools and programs, you can affect enough children in the community by supporting parents and their caregivers, their teachers, the directors, the principals, the people in the community, that only 5% rise up and need a higher level of care and go into infant and early childhood mental health. So what we did was use our dollars from Harris when I was in the field to think about how we could take the money of infant early childhood mental health and the consultation that was given to us by DOHMH, our Department of Health and Mental Health in New York, and then use that to connect to caregivers by doing Baby and Me music groups and thinking about with parents, the connection from the time children are very young And what we found was that a lot of parents are alone. What you're talking about, the perinatal stage, right? So before they're born, and then once they're born, parents feel alone in that phase. And so doing Mommy and Me groups created opportunities to think about what child development looked like. People started asking, should my baby be able to do this already? What can they be able to do? They just started showing up at the door some days because it felt like a community to them. They developed a community. So how do we create community supports that ripple out and don't require mental health until maybe we push up to that 5% level that infant and early childhood mental health consultation talks about?
All right, well, we are just a couple minutes before the close of the hour. I want to thank Rebecca, Tonya, Atiya, ECFC again for hosting this conversation. I think I understand from ECFC that there will be a broader series of discussions around how we really focus more support to caregivers and parents to get to better early childhood outcomes. And so there will be opportunity to continue the conversation. As an aside, there is a group in the works around maternal parent caregiver mental health funders that what we hope will unite early childhood folks, health folks, behavioral health folks, reproductive equity folks. We will promise not to spam you, but we'll send you information as that develops. I'm going to plug the Alliance for Health Policy on October 29th is doing an event on perinatal mental health. So there's the registration link, and I will let Rena close us out.
Thank you so much, Elizabeth and Atiya and Tonya and Rebecca. This was a really insightful conversation. We will archive everything that we've talked about, links shared, the event that Elizabeth mentioned, and the group that she mentioned when that information is available. Also, on November 4th, our next Thursday call will feature a conversation around how funders can help support building state capacity to implement ARP funds. And then also, I would like to put in a plug for an event in November that the Burke Foundation is a partner in, related to some of the work that they're doing, promising families, promising communities. Did I get that right? And we will include that information and registration in follow-up to today. So thank you everyone for joining us. We really appreciate it. Bye.